Spectrum on Radio 1 FM 90.
Spectrum wants to hear your views. You can SMS at any time during the show. Type Spectrum, leave a space, type in your contribution and name, then send it to 7197. Your views, our interviews on Spectrum, Radio 1 FM 90.
A very warm welcome. This is Spectrum on Radio 1. I'm your host, Edmond Kizito. On Spectrum tonight, the latest Ebola outbreak. How is the Ministry of Health handling the challenge, plus other sector concerns that make health service delivery a big challenge? The Ministry of Health is working around the clock amid several challenges to contain the outbreak of the deadly Ebola disease, which emerged at the weekend in Chibale district. So far, the disease has claimed 16 people, and it is reported that over 36 others are being monitored in health centers. Uganda is no stranger to Ebola, following several outbreaks in the past, which claimed many lives, including health workers. The latest outbreak in Chibale district was not quickly detected, as residents treated the disease as an act of witchcraft. But the Ministry of Health has now indicated that the situation is now under control after receiving help from the World Health Organization and other partners to contain the disease, which is very hard to detect because of its similarities with cholera. Today, Parliament suspended all visits by large groups. The Uganda Prison Service has also issued a ban on visiting prisoners, while in Fort Portal, all prisoners are being given police bond. Several hotels in Kampala have issued strict guidelines on how to be admitted to its facilities, as reports continue to suggest that Ebola could be in Kampala and other parts of the country. There are concerns about safety of health workers, given the past experience. But the Health Ministry says enough drugs and protective gear for health workers have been secured, and the training of health workers in selected districts has commenced. The Ebola outbreak came at a time when the ministry was still struggling to deal with the nodding disease syndrome in northern Uganda. It has also come at a time when medical practitioners are getting vocal about a crisis that is likely to affect the healthcare system in Uganda, calling for an overhaul of the system. So tonight we host the Minister of Health, Honorable Dr. Christine Ondoa, who will explain how the ministry is handling the outbreak and other concerns that have been noted in the health sector. You're most welcome, Honorable Ondoa.
Thank you, listener.
We also expect to be joined. We are going to be joined by Dr. Anthony Mbonye, Commissioner for Community Health in the Ministry of Health. He'll be joining us on the line during this program. Madam Minister, what is the latest news on the Ebola outbreak?
The latest news is that our number of cumulative deaths still remains at 16. And we have the total number of cases admitted at 30, and a total of 50 cases have accumulated since the onset. Now, the number of cases that are the contacts that have been followed up, these are the people who have ever come into contact with the suspects or with the dead, is at 232. So far, we have collected 37 specimens, and 5 have been confirmed with Ebola virus.
How do we expect it to pan out?
With the mobilization we have had involving our partners, the World Health Organization, the United States Center of Disease Control and Prevention, and Médecins Sans Frontières, Uganda Red Cross, and many others, we feel we will be able to contain this outbreak.
Do we know how it came, how we got to it?
Right now, the tracing so far we have done is that the index suspect, as we have always said in our report, is in Kibale.
Yes.
In Nyamuranda sub-county. We haven't gone beyond that. And of the 16 deaths, 10 of these were in one family, and the other 3 also in one family. Then the remaining 3 also within the same sub-county. We haven't confirmed any other suspicions outside this sub-county.
And is it something that interests your ministry to establish how it could have come? I mean, if you have 10 deaths in the family, that could have been the epicenter. Are you trying to investigate where the cause could have been?
Yes, we are trying to investigate. The Ebola virus has its reservoir in animals, the primates. These are the monkeys, the baboons, and also bats. Now, the community in this village, in this sub-county where the epicenter is, happens to border a kind of forest. And from the stories we receive from them that sometimes the monkeys from this forest actually come even up to their fields. So we wouldn't know how they got into contact with these animals, but commonly you get the virus to contact with body fluids. Like sometimes some communities kill these animals for meat, they kill them for other purposes. Or if you go to the caves where the bats actually deposit their secretions and other fluids, and you touch the caves and you have small cuts on your fingers, and so that's how you get the contacts.
So there's a possibility they could have contracted it from monkeys since they live next to a forest?
That's very possible.
They could have eaten monkey meat. Is that something? Is there a way of really establishing this? You had 10 people dying in one family. Mm-hmm. That's a large number. Mm-hmm. Do you have leads, either from neighbors or some other people who could give you
the
clues?
The thing with Ebola is it could just be one person who got the infection from the animal, and then because of its mode of spread, then the other families could have also got the infection. It may not be likely that maybe the whole family either consumed this meat or went to the forest or went to the caves. Yeah, but we are establishing that.
And at some stage we'll know what exactly happened.
Yes, and even now, after having this series of Ebola outbreaks in the country, we had embarked on what we call ecological studies. We're looking at the animal species from different parts of the country, especially the primate, the monkeys and so on, and the bats, sampling them from the forests, so that if a particular forest and the animals in that forest have the virus reservoir, we will be able to know, and we will know how to handle. But so far, the places where we have done these studies, we haven't established any, apart from the Marburg virus, which was
in Congo
confirmed. No, here, which was confirmed, yes, in one of the forests. That was some time back.
Marburg is similar to the Ebola.
Yes, it's also a viral hemorrhagic fever. So these studies are going on, and now because of the widespread of these outbreaks, we are expanding our horizon of the research, and now we are having Ministry of Finance come on board, the Ministry of Tourism, the Ministry of Agriculture, so that we put down resources together and expand the research.
And what would happen if you discovered it was in a particular breed of monkey? Would you call them?
Yeah, there are procedures. There are renowned World Health Organization procedures on how to proceed on that. So we will follow those protocols.
All right, well, listeners, this is Spectrum on Radio 1 tonight. The latest Ebola outbreak. How is the Ministry of Health handling the epidemic plus other sectors? Concerns that make health service delivery a big challenge. Our guest is Honorable Dr. Ondoa, the Minister of Health. You will be able to call in and contribute to this discussion at some stage. We also expect to be joined on the line by Dr. Anthony Mbonyi. He's the Commissioner for Community Health in the Ministry of Health. He'll be joining us on the line in a short while. Madam Minister, could you take us through this disease? Exactly what is Ebola?
Ebola is a virus, a very highly contagious virus. It's called viral hemorrhagic fever because of its symptoms of fever, hemorrhage, that is bleeding, and other symptoms like diarrhea, vomiting, and so on. Ebola derives its name from the river Ebola in the DR Congo. That is where one of the species of the first Ebola outbreaks was confirmed along that river. So then that's how it derives its name.
And how does it attack? What happens when someone gets it? They get in contact with fluids of an infected host, like a monkey or another human being. You can get it through handshakes, bleeding. Give us some detail on that, how one can contract it.
You get it through contact with body fluids. And these body fluids can include blood, tears, saliva, seminal fluid, vaginal fluid, any sweat, any body contact. And so it's worsened if you have cut wounds and so on. Then the transmission is even faster. In the laboratory setting, transmission of the aerosol transmission is possible, but in real life that has not been demonstrated. So it's not airborne. In the outside the lab, it's not airborne.
Right.
You can only get it when you have contact
with body fluid.
So
let's try to look at a scenario. You get in contact with these fluids. What happened from the over 12 or 24-hour cycle?
Then the virus, which is very tiny, gets into your blood and multiplies rapidly. And then the infection, the cascade of events in your body, the final thing is that it leads to multiple organ failure because of the multiple attacks and then that leads to multiple bleeding.
So, but let's look at the first 24 hours.
Yes.
What kind of symptoms would one get? Then I would like us to look at the structure, how the ministry is managing. But let's first of all isolate this disease.
Okay.
24 hours after you get into contact, what would have happened?
You may not experience anything because the incubation period is up to 21 days.
Yes.
That is why these cases we're tracing, we follow them up to 21 days.
3 weeks.
3 weeks. You may even double that to 42 weeks. Yes. You know, the virus, the Ebola virus, have several subtypes. There are subtypes that develop rapidly and are very fatal, and others are mild and take a while.
Right.
Yes.
Let's look at how we've been handling this. How has the ministry been handling the Ebola outbreak?
We have developed task force at the Ministry of Health headquarters and also the district task force. And these task forces are managing the disease outbreak in different ways. The clinical management, where those who put on like astronauts go to take care of the real patients. Then there's the management of the burial, those who bury the dead body, yes. Then there's the management of information like what I am doing now and disseminating it to the people. Then there's the one where we look at the logistics, what is needed, what is on ground. And then there's the mobilization of resources, funds, and human resource. So these outbreaks have like kind of been blessings in disguise for us, because we have trained several teams and we have people who have really had battle-tested field experience in Ebola management. So when we got this outbreak, we quickly recalled them from the different regions, Mundibujo, Gulu, Bombo, and so on. So they quickly came in to help. And then we had the advantage of the army. Many army also were trained in the Ebola management. So we mobilized them. And then our development partners have been very, very helpful. CDC and WHO, others flew expatriates, flew in some people to come and help us. And even funding. We've mobilized funding locally from our ministry. Even the Chibale district local government also mobilized money. Local partners also gave in money. And then other partners like Medicine Sans Frontiers, Red Cross, gave in kind supplies. You know, so that has been the kind of mobilization we've had in order to handle and tackle this. Then other people give psychosocial support to the counseling, yes, and even the people who are the least lined, those ones who are least lined, need counseling. It's a very, very stressful disease. You can imagine your dear one.
Those who've been bereaved, who lost people to Ebola, they need counseling, you say. Is that what you're saying?
The ones who lost their loved ones.
Yes.
Yeah, they need counseling. You can imagine losing 10 people in one family.
That's huge.
It's very huge.
It's kind of a war situation.
Yes. And even when your dear one is admitted with this disease, you can't see them, you can't reach them. You can't touch them, you can't talk to them. And worse, if they die, they're just put in a bag, bundled up, buried by some people. No burial rituals done. That is so dear to some of our cultures, but that is never done. You see, so you need to take people through counseling and assurance and all this, and it may not go on just one day. You continue visiting them. Like this 332, we visit them every day.
Yes.
Not only for monitoring whether they have developed signs or symptoms, but also reassure them and encourage them and all that.
Is the healthcare system well equipped, broadly speaking?
Yes and no. No, because generally the health system, we have challenges. Even without Ebola, we still have challenges. We need to do more to really bring the health sector to a standard that we wish it to be. And now when we get a challenge like this, you're faced with even more challenges. But with the resources that we've been able to mobilize, at least we have tried our level best, and we've got recommendations from World Health Organization and CDC Atlanta. World Health Organization even say that we have handled this very well according to international standards. And I had one comment from somebody in CDC in the US, I won't mention the name, but said it's good this outbreak occurred in Uganda because we know they have the capacity to handle. Assuming it occurred elsewhere, it may have been more disastrous. So to me, that is really a positive comment.
All right. Well, that's a strong comment there. We'll get back to the specifics of how we're handling Ebola, but let's broaden it a little bit. Some people have said, we hosted 2 doctors here yesterday, but some people have said broadly that our health structures could do better. We have a national referral hospital, which is operating like, to borrow the words of one of them, they are honorable members of parliament who are also medical doctors. They say the national referral hospital is operating like a healthcare center in the village, level 3 probably. It's not because we don't have regional referral hospitals, we don't have district referral hospitals. Why is that?
Partly is because of the way we have designed our healthcare systems. When you go to like a health center 2, the mandate is to treat the first level care. And then when they fail, they refer to health center 3. And then the mandate of a health center 3 is, even in written, it says it does all that health center 2 does, in addition to maybe providing maternal and neonatal care. Then level 4, it says it does all that health center 3 does, in addition to providing operations and maybe infectious diseases and laboratory work. Then you come to a regional referral, it tells you that it gives care of all that the others do, in addition to specialized levels. So even at the regional referral or at the national referral level, you still do the primary care plus the tertiary care, the secondary and the tertiary care. What does that mean? That means if somebody comes with a simple malaria or diarrhea and vomiting,
you still have to treat at
the national referral level. But also, these other regional referrals will refer what they have failed to manage to you.
Yes.
Yes. But I agree with the concern of people that if we are to have national referral hospitals, if they are to function as the level at referral only, then that means we will only be receiving referrals. If we get simple malarias, if we get normal deliveries, then we won't handle. But sometimes that is really difficult to draw that line.
Why? Is it because we don't have the structures at the bottom?
Not because...
So everybody ends up in Malaba because they don't have a hospital next to them.
Yes and no. Why sometimes people prefer Mulago is deep inside them they know that the doctors in Mulago, most of them have specialties. They are specialized in eye care, they are specialized in to deal with the heart, to deal with the issues of women and so on. So they know that when they come there, they get the best care. And secondly, they know when they come there, the people are around. But when you go to a health center, 2 or 3, sometimes because of staffing levels, there may be only 2 people or even 1. You may not find a person on station. So those are several reasons why people prefer other levels of care than others.
Well, I've spoken to some people who say that they go to Mulago. Some of them can afford to go to private hospital. But they say, we know even if we went to the best private hospital, if they fail, they'll eventually refer you to Mulago Hospital. How do you get to the ideal situation, Honorable Minister, where the referrals are really referrals?
That depends on us strengthening the lower levels. We need to equip the lower levels with human resources. Right now, the ministry has done well in terms of medicines and health supplies. Though we are not yet at our best, but we have tried. But we don't have enough personnel. So that's where we begin. If we have the personnel at all these levels, and people know that if they went, they will get service, probably these other regional and national referrals will be decongested.
So it's basically a personnel matter.
Personnel, and also strengthen our referral system.
Yes.
So that Mulago only now handles tertiary, secondary and tertiary care.
Yes.
Complicated cases only. And then we will tell people, we will only handle you at Mulago when you have a referral form from these other
So
units.
that should be the ideal. Mulago should
Yes.
not be a walk-in hospital.
Yes.
You only go there because you'll be referred by a lower hospital.
Yes, yes.
A regional referral hospital for that matter.
That's right.
And a regional referral won't touch you until you've been referred by a district.
That's right.
Do we have these physical buildings, regardless of the state in which they are, whether manned or equipped or whatever, do we actually have them?
Yes.
Across the country?
Yes.
2, 3, 4, all the levels.
That's right. Yeah.
Interesting. Well, listeners, this is Spectrum on Radio 1. Tonight on Spectrum, the latest Ebola outbreak. How is the Ministry of Health handling the epidemic, plus other sector concerns that make health services delivery a big challenge? We are going for a break. When we come back, we'll look at some of the other issues. Kampala, how far has it been affected? How did people like Dr. Lukuya die? Were they neglected? We'll be back to stay tuned.
So unbelievable na yatenga vya dala tekibadde ise yadde nakamo bendera waggulu bulaka tuli beautiful yero wakasana kafenga kasufu ready brotherhood eyatero bwetugatta
Tuchakale with Airtel today and celebrate 50 years of independence. Get up to 100% bonus to call across all networks. That's not all. Stand a chance to win a motorbike daily and a car every week. Simply top up every day. Get up to 100% bonus. Dial *162#. Press yes or OK. Start the 50 years independence celebration of Uganda today with Tuchakale from Airtel.
John, Mike and I, we go back a bit. We knew John at the beginning, working for someone else. But he was different. He had vision, saw opportunities. He started working towards his goal, opened his own garage, and worked, learning the hard way. His reputation spread. Trust, consistency, quality. Soon people were coming to him from all parts. He made himself and his whole street prosper, and also helped friends, seeing potential in people and helping them on. But John never shouts about all his success. He is just who he is. Special.
So here's to men like John, who make a difference, who enjoy Nile Special, the rich, satisfying taste from the source. Nile Special.
You've earned it. Not for sale to persons under 18.
Spectrum on Radio 1 FM 90.
Welcome back on Spectrum. Tonight, the latest Ebola outbreak. How is the Ministry of Health handling the epidemic, plus other sector concerns that make health service delivery a big challenge? Our guest tonight is Honorable Dr. Christine Ondoa, the Minister of Health. You will be able to call in and contribute to this discussion at some stage. Madam Minister, we hear reports that in Mulago, some contact persons could have spread it in Kampala. How safe is our capital city?
It is true we had one case of death from suspected Ebola case in Mulago. This occurred, I believe, around 16th of July. The case was a clinical officer who handled the suspected Ebola cases in Chibale. So when she fell ill, at that time we had not yet confirmed that this is Ebola. We were treating a strange disease. Remember, we confirmed that it was Ebola on 28th. So this was before. When she fell ill, and because of the way the disease presented, and then you are very sick shortly after that and you died, so the doctor thought, this is a clinical officer, a health worker, let me refer her to the best facility to be handled. So she was properly referred by an ambulance to Mulago Hospital. So she was received in 3B emergency, and before even they could transfer her to the admission wards, that's where she died. And then when we confirmed later on 28th that actually what we are dealing with was Ebola, then we thought probably this lady also died of Ebola, because we did not get to confirm it
at the time that she died.
At the time that she died. But all the people she came into contact with in Mulago have been isolated and are closely being monitored. Yes, so that is the only death we have in Mulago. So of the 16 deaths that we are reporting,
only one.
This one is among the 16.
Right. So there's no possibility that Ebola could have spread any other way through that person in the city.
We cannot say that yet.
Well, you can't rule it out, but generally speaking, through this point, you don't think there were contact people who could have spread, who would have gone out with it. You carried out all the necessary measures to prevent that happen.
The measures we've done so far is to isolate every person who has come in contact with her.
Right.
Isolate them, and we're following. You remember I said the follow-up is 21 days, even up to 42 days. So we cannot say anything yet. But so far, none of these people have developed symptoms yet.
Right. How about the health workers? Are they secure? We know about Dr. Lukwea, it keeps coming back. It haunts a lot of people. Are the health workers safe?
When you're handling this case, before you know it is Ebola, you are not safe at all. To handle Ebola, you need what we call barrier nursing.
Come again?
Barrier nursing.
Yes.
You see our people in
dress
pictures.
Like
astronauts, yes. That's what you need. Short of that, you are exposed. Today we got a report of other health workers in St. Ambrose who possibly could have also managed similar cases. We are also following that up.
Where is St. Ambrose?
In Chibale, one of the centers where these suspected cases are. So all these people, we're following them up and seeing and monitoring to see if any of them will fall sick or have these symptoms. We take specimens to make sure that they have not been infected. So unless you have the protective gear,
right,
then you are not safe at all.
You're at risk.
Yeah.
Do the doctors get a health risk allowance?
Yes. These particular ones get risk allowance, and those who died, we have been compensating them. And even this, we are discussing how we can have them compensated.
All right. And Madam Minister, what could you say are the successes you've registered
in the Ebola management?
Broadly speaking,
one, we have experience. You cannot buy experience or pay for it. You get it by experience. Experience is got by experience.
Yes.
2, we have upgraded our laboratory at Uganda Virus Research Institute at Entebbe,
right,
to be able to isolate this virus without now having to fly them to USA Atlanta or South Africa or elsewhere. This is a very big achievement for our country.
When did this happen?
Of a year ago.
It's a recent development.
Yes. So those are, and our public is aware. I mean, imagine they called us early July that this is strange disease. This is strange disease. Much as this disease was presenting like cholera, but the people were able to say, no, this is a difference, and called us and alerted the health workers. So somehow these are really big successes. And you remember the comment from one of the US citizens that
Yes.
is good is happening in Uganda.
Because they have the capacity.
They have the capacity, they have the experience.
And
Yeah.
what are the failures, the challenges that you're still grappling with?
The failure is that we have not maintained the isolation wards properly. Because each time we get outbreaks, we have to do new reconstructions or so on. At this level, we really should be ready at all times, so that even if it broke up in Jinja or Moroto, there should be some kind of structure. So we should be aware, we should be ready. The type of readiness we still lacks in us.
Honorable, how different is the Ebola virus from other epidemics? This Ebola epidemic, how different is it from other epidemics?
It's different because it kills very fast.
Yes.
It's very deadly. It's highly infectious.
Very deadly, highly lethal.
Yeah.
And it's highly infectious as
Yes. And kills in a few days.
well. How did it compare with others like cholera?
Cholera is a bacterial infection.
Yes, it's not a virus.
Ebola is viral.
And viruses you cannot treat.
Most
You cannot
viruses
treat
don't have treatment. Yeah.
them. So cholera can be treated.
Yes.
Ebola, you'd better keep it out of your system.
Yes. But the similarities in both of them is prevention is better than cure. We need to prevent them. Cholera is orophycal. You eat it.
Yes.
Ebola, you transmit it by body contact and sexually. By the way, those who have the Ebola virus, even after survival, they can still transmit it sexually even after 45 days.
Oh, really?
Yes.
It stays with them for good.
Yes, after 45 days.
Once you've got Ebola,
Yes.
you can still transmit it for life, sexually, like you say.
Not for life, up to about 45.
45, 1.5 months.
Yes.
After that, you're clean. So people should avoid indiscriminate sex. Somebody said, yeah, prostitutes should actually go home for as long as Ebola is around, because they could infect many people.
100%.
What can we do to improve our systems to manage such outbreaks for the future?
We really need to strengthen our health systems.
Yes.
I mentioned we need the human resource, the numbers, the quality, and also to pay them better. I can't say more.
Well, but the budget you keep getting, last year you had about 9% of the budget. The target is about 10%. And this year it fell to maybe between 6 and 8%. I don't have the exact figure. Do you see us moving in the right direction?
Most of the monies allocated for us are for operational costs. They are for running the units. But if we had more for salary enhancement or salary increment or for employing more, then the budget will have gone up. But of course, you also look at the national basket. It's not that big. And many people, many departments, many ministries are sharing that. For us as a health sector, we want to think out of the box. What as a health sector can we do to improve the situation of our health workers? There are many things we are thinking about. We are in the last stages of finalizing that proposal. So we'll share it with the cabinet, and maybe after that it goes to Parliament, and we see whether it will be accepted.
What kind of it? Having a commercial wing at some?
Yes,
well, you have
that's one of them. Yes.
And that could help pay staff as well.
Pay staff and even recruit some on contract basis, construct decent houses for them, meet some of their expenses. For instance, if they lose dear ones, the hospital takes over. Or when they are getting married or their children are graduating, we contribute.
And you think this will be carried through?
We are hoping so.
There was a health sector review sometime in 1988, I believe, 89, and 88, 89. it was a beautiful document that was never followed upon.
Most of those we are reviewing them. Actually, we have incorporated them into the new ideas that we have, and we want to discuss them and have them really considered.
All right. Perhaps maybe before we hear from the listeners, what does the future look like
For the health sector?
on Ebola specifically?
I think for now it is bright. We are containing the outbreak. But of course, until we have the last case, until we have followed through, we cannot say never. What I promise the public is we will continue updating them daily. And if the situation won't look good tomorrow or the day after, I will say so. But now, for now, I will say we are containing it.
And how different is this one from the one that we had in Luero, where just about one person died, and in Gulu before that, where Dr. Matthew Lukuya died?
The Luero case was typical presentation with all the symptoms, including hemorrhage. And the doctors there were very, very bright. So they suspected it immediately, and then it was confirmed. So all the family were cordoned off. They were isolated and followed. And luckily enough, no other person died except only this one case. This other one is a little tricky because we took long, over almost like a month, to confirm. And so you can see the different people. Others came to Mulago. We don't know where others have gone, but we are tracing them. So the Luero case, instantly it was identified. This took a bit long. And you know, with movements, you can have many other contact listings.
So we still have a weakness there in our healthcare system, early warning system in the health.
Yeah.
Is that something we can work on, or is it an act of God? We have to pray harder.
This particular one, I won't say it was a weakness. Actually, I really commend the health workers for this work, because the way this Ebola presented initially, it was like cholera.
Yes.
Fever, vomiting, diarrhea. There was no bleeding. And at that time, we also had cholera outbreak in Kibale. So we thought
it was disguised.
It was disguised. Then, because they were red fat, we thought maybe this is a serious bacterial infection. And even at that time, investigations were going on in the laboratories in Kibale and here at the Central Health Laboratories on Buganda Road. But we were looking for bacteria, not a virus, until one of the specimens that was sent to the Public Health Laboratory was a bloody stool. And my health worker was so smart. He said, "Oh, bloody stool. There must be a problem. Uganda Virus Institute, please look at this specimen." And that's how we caught it. So you can see how brilliant that fellow was.
Wow.
Yeah. So I also imagine if this case was typical presentation with bleeding, we would have caught it very, very early.
And do not have had these deaths.
Well,
listeners, this is Spectrum on Radio 1. Tonight, the latest Ebola outbreak. How is the Ministry of Health handling the epidemic, plus other sector concerns that make our health service delivery a big challenge? You can call in now. Our number 0414 348 111 0312 260 390 0312 261 390. When you call in, please tell us your name and switch off your radio if you can. Spectrum, hello. Hello.
Good evening, Edmond.
Good evening, sir. Your name?
Edmond. I want.
Spectrum, hello. Hello. Okay, Spectrum, hello.
Hello.
Yes, sir. Your name?
Yes, good evening. My name is Andrew.
Yes, Andrew.
Thank you for holding.
question clear. Do you think there could be a possibility that your Ebola virus is what?
Could it be
Yes, your second question now.
Yes, please.
All right, Spectrum, hello. Good evening, sir. Your name? All right, Spectrum, hello. Good evening to you.
Richard from Jerusalem.
Spectrum, hello.
Hello.
Yes, sir. Your name?
Adorable. I want to ask.
Spectrum, hello.
Yes, like Spectrum. Good evening.
Good evening, sir. Your name?
My name is Godfrey. Now,
Spectrum, hello. Please switch off your radio and then talk to us. Your name? Please switch off your radio. You're live on Spectrum. Your name?
Yeah, Warren is my name.
Warren, we lost you. You can still call back in. Our number is 0414-348-111, 0312-261-390, 0312-260-390. Spectrum, hello. Hello. Yes, sir. Your name?
Jack.
Jack, yes?
And I'm going to Maya.
Yes.
I would like
All right, let's get back to the studio. Honorable Minister, you can take us through the questions.
I want to thank all the listeners and those who have phoned in. Your contributions are very, very helpful, and thank you for appreciating what the Ministry of Health is doing. Katatumba called about salaries, whether at such a point in time salaries are important or relevant. Salaries are important, not only in epidemics, but in generally boosting morale of health workers and any other public servant. I mean, when you go home with enough that can take care of many of your issues, your morale at work is boosted. That is the point I'm trying to make. But during epidemics like this one, the numbers matter more. I need more health workers now than ever before. Because for an outbreak like Ebola, you will only subject the health worker for a maximum of 8 hours to work in that protective gear and in that ward where the patients are.
During the day?
During the day or even in the night. Only maximum of 8 hours.
They can't go beyond 8 hours?
No way.
Wearing that gear?
Not even the gear, but when you're fatigued and you're tired, then you'll make a mistake.
Right.
Because here you have to follow certain procedures.
It's a high concentration
job. And perhaps that was what is said of the late Dr. Martin Lukuya. He worked for long hours, he was exhausted, and he made a mistake, then got infected. So that means after 8 hours I withdraw this health worker and I take in another one. Then perhaps after 1 week, this particular group, I bring them away.
You bring another shift.
I bring another shift.
So numbers are really important.
In epidemics, numbers are very, very important. And even the money, we need to give them risk allowances. So it is true, salaries and allowances are important now, but more so the numbers.
All right. Could it be airborne, Andrew?
Andrew says, could it be airborne? No, there's no research outside the laboratory that proves that Ebola is airborne. That is the only answer I can say.
Right.
And then
Minister of Health guidelines to workers.
We have the guidelines in place already. If you go to most facilities, you'll find the posters
on the walls
on the walls on Ebola previously. But even now we're doing more posters. We're doing more guidelines. We have the guidelines, and we have what we call case definition for each disease, and for Ebola it's also there.
How you tell a disease?
That if a patient presents with these symptoms,
then you know it.
Then have a high index of suspicion. So sometimes, like now, we may go up to even 1,000 cases, suspect cases. That's good for us. It's better to have more suspects and you catch one among them than not suspect at all.
All right.
And then
wear a protective gear.
We had enough protective gears in the previous outbreaks, and we even distributed them to the regions so that each region has the gears and has the supplies and medicines. So that if an outbreak occurs in the north or in the east, they don't have to run to the center. They already have them. And
there was a consignment that came in from a donor recently.
Yes, but even before that consignment came, when we had this outbreak, these were the protective gears we mobilized from the previous distribution.
Okay, Richard in Chireka, restrictions on movements, would you quarantine some places?
At the moment, no. WHO guidelines, we have guidelines from World Health Organization, and you look at the level of severity, so to say, just like security, level 1, level 2. If it reaches level 4, then you have like curfew. And that's what we do with epidemics. If it's level 1, level 2, no worry, no ban on movements.
Right.
But if it reaches a certain level, then we say this community, no movement. But we haven't reached there yet.
All right. And we don't expect to reach there because you think it's been contained.
Yes.
Katuramu, Chenjojo, Mbarara, Kasese, and Fort Portal, are they at risk at all?
Yes, they are at risk, and we are addressing that. We have extended our training and education and awareness. We're extending it to the neighboring districts and also distributing the protective gears and supplies and so on, so that this, especially the neighboring districts, are also ready.
Because they're neighbors, they are at risk, not empirically. It's not that you've noted cases there, but
yes, we're preparing, proactive.
Proximity. Let's talk about Godfrey's question. Ministry of Health, are you working with the World Health Organization? He also says in this seems to be an East African problem. DRC, Uganda, Kenya.
Yes, we're working very, very closely with World Health Organization. They've helped us with personnel, they've helped us with money, they have helped us with these guidelines, and they are helping us with the monitoring. We're also working very, very closely with United States Center for Disease Control and Prevention.
That's the Atlanta-based group, I think. Is it?
No, even we have CDC here in Uganda.
Right.
But they have also sent in more workers to help us.
Right.
And then other partners like Medicines Sans Frontières,
The French group.
and other development partners are also with us.
All right, Jack in Maya says preventive measures, you've already addressed that. Maybe before we go, Honorable Minister, and we must thank you for coming tonight. The nodding disease, how far have we gone with it? Do we have any breakthroughs there?
Unfortunately, this Ebola has unmasked the international conference that is running now. We just ended an international conference, the first of its kind in the world, on nodding syndrome here in Uganda. It was done in Sheraton Hotel, where very many professors, academicians, researchers from all over the world, and countries that had ever experienced nodding syndrome, and those who still have, are attending the conference. And we had such a beautiful discussions and contributions. And Uganda, incidentally, people, you need to hear this and congratulate us. We have moved more than any other country in the world concerning the management of nodding syndrome. We are the first country that has ever produced a guideline for nodding syndrome. We are the first country that has ever set up treatment centers for nodding syndrome. We are the first country that has acknowledged it and even now is willing to include it among the neglected tropical diseases. The Ministry of Health in Tanzania had nodding syndrome since 1963. But in this conference, they clearly said that for them, their ministry doesn't recognize it. Doesn't pay attention, doesn't give particular attention to it. They just treat it like any other type of epilepsy. I wish people could hear this and give us 2 thumbs up.
Well, they've had it. Do we have a breakthrough soon?
We're hopeful because now with all these partners that we have attracted, many more want to do research into what is causing this syndrome. How can we treat the children better? How can we improve their lives better? So we are hopeful that we'll be able to handle it. And even now with the treatment protocols we have, many children are improving. And there are reports that even others have gone back to school.
Well, we must thank you very much, dear guest, special guest, interesting. Honorable Dr. Pastor Christine Ondoa, the Minister of Health. She was appointed by the President he had never met her. That was a remarkable thing.
Thank you.
Thank you very much for coming to Spectrum. Thank you for tuning in. I've been your host, Edmond Kizito. Spectrum will be back tomorrow. Up next is the news in English. Do stay tuned.
You can pay, you can buy, pay your bills, pay school fees, send cash overseas.